हेलो। हेलो मुकेश भाई।
हाँ। हेलो।
हाँ आ रही ना आवाज। नहीं
हाँ
एक्चुअली क्या
आ
हो गया।
रही। हाँ।
हम्म।
ये मेरा वीडियो बंद कैसे होता है?
कोई बात नहीं
नहीं,
कोई
अभी
बात नहीं।
अभी नहीं है, अभी नहीं हो रहा है ना।
हाँ अभी नहीं अभी चालू है। इसको प्रेजेंटेशन मोड में डाल दीजिए।
प्रेजेंटेशन मोड।
प्रेजेंटेशन में ही होगा आपके नीचे। जय ये बार बार क्यों लेफ्ट हो रहे हैं, मे भी अलग इसमें से ऑटोमेटिक लेफ्ट हो गया कुछ बाद में नहीं होगा ना ऐसे।
नहीं नहीं, वो नेट का इशू रहेगा ना, तो इसके वजह से तो।
मैं तो वाईफाई पे हूँ। आई थिंक होना तो नहीं चाहिए।
क्योंकि स्टार्टिंग में ज्वाइन किए थे ना, तो आपका सिर्फ ऑडियो ही कनेक्ट हुआ था।
अच्छा अच्छा।
नहीं तो मेरा ये शेयर प्रेजेंटेशन तो मेरा दिख रहा है ना।
दिख रहा है दिख रहा है।
हाँ
आपको भी दिखेगा।
हाँ हाँ। नहीं, मुझे नहीं दिख रहा है।
नहीं आप
सर ने हाइड कर दिया रहेगा।
हाँ आपने हाइड किया होगा, चलो कोई बात नहीं। आप उसको शेयर अनशेयर कर सकते हो ना लेकिन।
हाँ हाँ। तो मैं आंसर करूंगा, सब जाके डॉक्टर शेयर करेंगे ना।
हाँ आपको अनशेयर करना पड़ेगा तब तक नहीं कर पाओगे।
हाँ हाँ हाँ।
इनकेस आप नहीं कर पाओगे तो जय कर देगा वहाँ से, है ना जय।
यस सर, यस सर।
हाँ ही कैन डू इट।
स्टॉप शेयर करके अभी स्टॉप शेयर कर दूं, क्या
नहीं
रहने
नहीं
दूं?
अभी रहने दीजिए, अभी तो कोई
हाँ
दिक्कत नहीं है, अभी तो यही स्लाइड पहला है ना।
हाँ हाँ
जय अपने टेक्निकल सपोर्ट में है, थर्ड पार्टी है।
हाँ हाँ
सर्विस प्रोवाइडर तो जैसे ही वो बोलेंगे कि वी आर गोइंग लाइव तो वो
हाँ।
मोमेंट से लाइव हो जाएगा वो, ठीक है 1 2 3 करके हम लाइव
बराबर
जाएंगे।
बराबर। हाँ
देन यू स्टार्ट इमीडिएटली गुड मॉर्निंग करके
हाँ
एंड
हाँ।
दिस इज हाउ वी विल गो एड।
यस यस।
और चैट बॉक्स दिख रहा है आपको सामने, उसमें क्वेश्चंस आएंगे, उस पर क्लिक करके देखिए चैट। जय कुछ
हम्म।
डालो वहाँ पे चैट में।
देखो, मेरा वीडियो ऑटोमेटिकली बंद हो गया।
कोई
वीडियो
बात
बंद
नहीं
हो
कोई
जाएगा तो
बात
भी
नहीं।
मैं बोल दूंगा, बराबर क्या?
हाँ 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 आप
चलेगा
चैट।
ना?
हाँ अभी चैट
हाँ।
चैट 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 आया, कुछ चैट चेक कीजिए चैट में। मैं
क्वेश्चन
तब तक
आंसर ऐसा करके है ना?
हाँ।
क्वेश्चन आंसर।
नहीं 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 वो नहीं चैट में।
चैट का ऑप्शन। एक नहीं आ रहा है।
है ना आपके सामने क्वेश्चन आंसर के
नहीं,
साइड
देखो,
में ये
ब्लैक
चैट।
म्यूट है, वीडियो है, पार्टिसिपेंट है, क्वेश्चन आंसर, न्यूज शेयर, पोस्ट। बस चैट का ऑप्शन ही नहीं है।
जय
हाँ
ऐसे कैसे होगा।
अभी अभी। हाँ
ओके।
हाँ हाँ अभी दिख रहा है।
ओके बढ़िया। ठीक है तो वो स्क्रिप्ट जो है वो आपके पास है ना, मोबाइल में है, कैसा है कहाँ पे है।
इसमें हाँ, हेलो गुड मॉर्निंग करके आया चैट में। तो प्रेजेंटेशन आप शेयर कर दीजिए ना, डॉक्टर का प्रेजेंटेशन के डॉक्टर खुद करेंगे।
सर का सर खुद करेंगे, ये वाला आप रखेंगे।
हाँ बराबर।
इसका रिकॉर्डिंग भी होगा मुकेश जी, और ये यूट्यूब पे भी जाएगा, बाद में आपके साथ में लिंक शेयर करूंगा, सर के साथ भी करेंगे।
हाँ
इसमें आपका भी पार्ट रहेगा रिकॉर्डिंग में।
हाँ हाँ।
8 मिनट बाकी है मुकेश जी।
हाँ हाँ।
उसको प्रेजेंटेशन मोड में डालिए ना, नीचे होगा
किसको?
ना प्रेजेंटेशन, ये जो आपने शेयर किया है वो स्क्रीन।
ये कैसे करना है लेकिन?
नीचे नीचे है ना,
प्रेजेंटेशन
बॉटम में, राइट बॉटम में नीचे है।
नीचे कुछ आ ही नहीं, नीचे तो पूरा पूरा स्क्रीन मुझे दिख ही नहीं रहा है।
नहीं, डबल क्लिक कीजिए स्क्रीन के ऊपर।
ये कौन सी स्क्रीन हमारी?
आपकी स्क्रीन, हाँ, ये जो
हाँ
सामने है।
हाँ, इसको मैं कर रहा हूँ तो भी नहीं हो रहा है।
सर स्लाइड शो लिखा है ना एकदम ऊपर।
एक मिनट, स्लाइड शो।
हाँ, एनिमेशन के बाजू में।
हाँ, वहां से भी हो
मुकेश जी,
सकता है।
मुकेश जी,
हाँ हाँ
आपके नीचे देखिए 70% लिखा है, वो दिख रहा है नीचे 70%, राइट
नहीं,
लोअर कॉर्नर में।
नहीं दिख रहा है।
राइट के आप हमारे स्क्रीन पे दिख रहा है, आपको दिखेगा ही। नीचे
हाँ
जो
हाँ
व्हाइट बॉक्स है ना, उसके नीचे 70% लिखा है, देखो।
हाँ, एक मिनट। नहीं।
कोई बात नहीं, ये जो ऊपर है ना स्लाइड शो करके,
हाँ,
हाँ,
वो
ऊपर टॉप
स्लाइड
में।
शो भी नहीं दिख रहा, पोस्ट शेयर ये सब दिख रहा है, रिमोट कंट्रोल।
ये नहीं,
वो
ये
नहीं
नहीं,
नहीं,
आपके पावर पॉइंट में देखिए।
प्रेजेंटेशन में जाइए,
आपका पावर
प्रेजेंटेशन
पॉइंट
में,
का जो है ना, उसमें।
हाँ
स्क्रीन पे नहीं।
यस, ये।
हाँ हाँ हाँ, ये इधर इधर, हाँ,
ये हो
हाँ,
परफेक्ट
बस हो
परफेक्ट।
गया, हो गया।
बस बस, हाँ हाँ।
हाँ। 5 minutes to go.
यस।
Check the registrations. ओके जी, एक बार आपकी टीम की इसमें डाल दीजिए,
हाँ
रजिस्टर्ड डॉक्टर को ज्वाइन करने के लिए
यस यस।
और कॉल करने के लिए।
हाँ हाँ
अगर चाहिए तो आपको एबीएम से कॉल करना है तो कर लीजिए, वी हैव 5 minutes।
हम्म।
अब म्यूट कर
नहीं,
लीजिए।
बात हो गई मेरी।
हो गया ना? हाँ, बढ़ गया, रजिस्ट्रेशन तो बढ़ गया, अभी 30 हो गए।
हम्म। अभी सबसे बात हो रही है, टीम फॉलोअप ले रही है।
ओके ओके ओके, हाँ थोड़ा और।
नहीं,
आपका वीडियो जाता है मुकेश जी बीच बीच में।
हाँ अभी आया।
आ गया। वो पुराने टाइम का टीवी हो गया, उसको थोड़ा ऐसा मारो साइड से आप।
2 minutes to go. बराबर।
या 2 minutes हो या। मेरा वीडियो बंद कर देता हूँ मैं। ठीक है मुकेश जी, वीडियो गया आपका। कोई बात नहीं, मतलब बट देखिए चालू हो रहा है तो बी गुड।
फिर से बंद हो जा रहा है अभी, ऐसा कैसे है अभी?
नहीं, वो सॉफ्टवेयर और आपके हार्डवेयर का इशू है, ये इसमें नहीं है कोई दिक्कत। अभी दिख रहा है।
अभी ये ऑटोमेटिक बंद हो जाता है अभी।
हाँ ठीक है, कोई बात नहीं। ऑल सेट सर?
All set, all set.
Yeah, Mukesh ji and Dr. Piyush Joshi, over to you. I'll just be on mute. If anything comes, then I will interrupt definitely.
We are live, sir. We can start.
Yes.
Wait.
Yes, sir.
We can start?
Yes, sir.
Okay. Then on the count of 1, 2, 3, let's go live.
Good morning, all. I am Mukesh from Zydus Synovia. Welcome you all to the online learning platform, Ruma DG Conclave. Today, we having with us a very well-known consulting rheumatologist, Dr. Piyush Joshi. Welcome, sir, and thank you very much for our time today, sir. Dr. Piyush Joshi is a DNB in rheumatology and immunity. Currently practicing at home Hope Rheumatology and Hemato-Oncology Clinic, Bapunagar at Ahmedabad. Dr. Piyush Joshi has also practicing in Avron Hospital, Navrangpura, and Sterling Hospital, Ahmedabad. Today, he will take us to the very interesting topic, Chikungunya Arthritis. Please note, if you have any question, you can type during the session in the chat box at the bottom of the screen, and we will take all the queries at the end of the session. Thank you very much, sir, and over to you, sir.
Yeah, hi. Am I audible properly?
Yes, sir.
Yeah, okay. I need to share my screen. Can you stop sharing yours?
Yes, sir.
Okay. So yeah, share. Okay, just a minute. Ready? Okay. Yeah. Am I visible properly now?
Yes, sir.
Okay. Hi to all of you. Today my topic is slightly difficult and maybe very current and present what we are facing right now. It is a chikungunya arthritis that I'm going to talk about right now. So chikungunya arthritis is a disease that caused by infection with chikungunya virus. It began in Africa in 2004, and over the last 15 years, it has spread to more than 100 countries in 4 continents. So it is, and chikungunya arthropathy is one of the only chronic arthritic viral chronic arthritis which is there, and it affects multiple cell types, and it is coming to the level of pandemic right now. So it was starting as an epidemic, but more and more countries are affected, and it is now being considered to be a pandemic also. So my our presentation outline will be, we will be knowing our enemy better. So we'll be knowing more about chikungunya virus. So then talk about some epidemiology of it, how it progress and do the pathogenesis, how clinically it present, what is the diagnosis and treatment, in special situation how we manage them, and in future what lies ahead. There's a Japanese proverb that says that always know your enemy better, and you know yourself, and then you can fight the battles much better and without many catastrophe. So we should know our enemy much better. So we know it is a virus, but amongst virus we don't know many things. So the Baltimore classification of virus basically classifies the virus in three things. Either it is a DNA virus, RNA virus, or it is a reverse transcriptase using virus. So our virus, there's a chikungunya virus, lies in the single-stranded RNA virus. There is a positive sense virus, and that comes in the class 4. So this difference is basically how the virus forms its nuclear material. So if it is a DNA, it goes to the nucleus and forms the DNA material. If it is an RNA virus, it can go to the nucleus and form the DNA, or it can form directly from the mRNA in the cytoplasm. So this one figure comprises all the things. The first is double-stranded DNA virus. Second is single-stranded DNA virus. The group 3, 4, and 5 are the RNA virus, and group 6 and 7 they are the reverse transcriptase kind of virus. So amongst the patient with a group 4 virus, that is the alpha virus family, you can see there are many viruses. Now there's certain common characteristic that is there. They all cause fever, rash, arthritis, and encephalitis. So you will see this among all the viruses, and also chikungunya can also cause all of them. So chikungunya is a mosquito-borne alpha virus. It is a single-strand positive sense RNA virus. There are
Hello.
4 virus lineages. Why this is important? Because when you are forming a vaccine, there is a vaccine is available only to one lineage. So we are going to need the vaccine which will be needed for all 4 lineages. There is an African, West African, East Central, South African, and Indian Ocean lineage. And on an average, when a person gets chikungunya, they lose around 10 working days. So the epidemic has started. Initially the chikungunya virus was present in monkeys. So the cycle was from mosquito it goes to monkey, and from monkey again goes to mosquito. It was not coming to the humans. But the first reported case of chikungunya happened in 2004, where the chikungunya virus was first isolated in Lamu Island in Kenya, and from there it is spread to all over the world. In India, it started in around 2005, and still it is persisting. Every third or fourth year, we are having an epidemic of chikungunya in our population. The endemicity of disease remains, but every third or fourth year, we are having an epidemic also. So what transmits this virus? So basically Aedes aegypti and Aedes albopictus. These are the two mosquitoes which transmit the virus. In Africa and America, Aedes aegypti is much more common. In India, we find Aedes albopictus also plays a major role. So you can see this mosquito bite. They have a black body with a white stripes, and they are a day biters. So they mainly feed on you during the daytime and early dawn time. So once the mosquito bites you, the virus goes inside your skin. In the skin fibroblast, it goes and it starts to divide. So it grows inside the skin fibroblast. From there, it goes to the your blood system, and it goes to the all over the body. So it goes to your brain, where it goes to the epithelial and endothelial cells. It goes to the lymphoid tissues, in joint, in fibroblast, chondrocytes, and osteoblast, in muscle, liver, everywhere it goes. Once inside the cell, what happens is that it gets receptor mediated endocytosis that you can see here. Then from there, nuclear material of the virus get replicated inside the cytoplasm, and the Golgi membrane have a capsid formation, and both they combine and they do the virus shredding. Now how it affect the how the virus do the damage. So if you see, the initial involvement happens in the synovial fibroblasts, macrophage, monocyte, chondrocyte, and osteocytes. From there, various molecules are secreted. Now, because of the COVID, we know the IL-6 and TNF very commonly now. So the IL-6 and TNF play a major role at the start, and they lead to the chronic phase. That is the recruitment of the other cells, which leads to the chronicity. That is the Th1 type of helper cells, NK cells, NKT cells, Th17 cells, which play a major role. And from there, various molecules comes into picture, and then that drives the autoimmunity for a longer time. So if you see, the initial response is interferon response. Now this is very important. The interferon beta is a protective for viral virus in our body. Now interferon beta works very best at around 37 to 38 degrees centigrade. The peripheral joint have slightly lower temperature of around 2 degree, which reduces the interferon activity by 40%. And that's why the arthritis affection is mainly peripheral. And you see more and more people coming with the peripheral joint arthropathy rather than central arthropathy, because of the varied interferon response in patient with chikungunya. After fifth day, the antibodies come into picture and T cell come into picture. Now, if you see, the initial is interferon, but later on interleukin 6 and TNF plays a major role in deciding the clinical presentation of disease. Now, amongst the clinical presentation, initially the viremia happens. From the day of viremia, around second day, you will start to have fever. Viremia, from the day of bite, the viremia happens after fifth day. The fever happens around fifth to seventh day. Arthritis also happens at the same time. The fever is generally high grade in nature. Generally, it lasts for 4 to 5 days, but most cases, it mostly lasts for 2 to 3 days only. Arthritis is generally sudden onset, involves all the joint at once. It's a symmetrical arthritis like rheumatoid arthritis, but the peripheral involvement is much more common. The hand and feet involvement is much more common in this case. Now, there is a incapacitating arthritis, means patient is lied very okay in the night, and in morning the patient wakes up and they have a stiffness. He cannot get out of the bed. This generally do not happen with rheumatoid arthritis. They're very common with the chikungunya arthritis. The myalgia and skin rash happens on fourth or fifth day. Skin rash we have to mention very clearly here. Now, this is a maculopapular rash that happens on fourth or fifth day. What happens that someone comes with chikungunya, you start treatment, you give NSAID, the next day they came with rash. So we think it is a drug rash. No, no. On fourth or fifth day, it is not drug rash. It's a chikungunya rash, and you should not stop NSAID because of this rash. It is because of the chikungunya. It's a maculopapular rash that mainly involves trunk and extremities. Generally, the face, palms and soles will be exempt from the rash. So that's how you can differentiate the chikungunya rash from the drug rash. So initial 4 5 days you can detect by PCR. Once the fifth or sixth day happens, you should not do PCR tests. Then you should do the chikungunya IgM test. And from around 15 day, you should do a IgG test and not IgM test also. So in the incubation period is around 7 days. From the day of onset, you will have fever. You might have other features like headache, retroorbital pain, gastrointestinal symptoms. You can have lymphadenopathy. You can have. You might have a lymphopenia, thrombocytopenia, increase in creatine kinase, and hypocalcemia. In subacute phase, just a minute. In subacute phase, you will not have all these features. In chronic phase, you will have post-infectious chronic rheumatism. You will have musculoskeletal pain and problems. You might have asthenia and depression, and you might have headache. So in acute phase, generally lasts in young patient. It is much more severe. There is a high-grade fever, rash, and arthritis. Along with that, there might be hepatitis, there might be muscle involvement in myalgia, there might be spleen and adenopathy, which is there. In CNS, there might be a Guillain-Barré syndrome also, and there might be encephalitis in such patients. So in acute phase, what you see, other than the routine symptom, you might develop diarrhea and edema, which might be the other presentation that patient might be coming to you. In atypical acute stage, you might get neurological things like encephalitis, GBS, meningoencephalitis also. So patient can come in a drowsy state or altered mental status also. In cardiovascular state, patient can come with myocarditis, arrhythmias, and hypotension. This is much more common in older age people. In renal, patient might come with a nephritis and proteinuria. There might be respiratory failure and dyspnea and pneumonia, which might be there in patient alongside. In severe acute chikungunya arthritis, you might develop multi-organ failure. So there might be multiple organs which are failed, and there is much more mortality in this patients. Generally requires hospitalization, and these patients are generally elderly and diabetic in nature. Now, chronic phase generally comes in around 25% patient at 2 months and 15% patient at the end of 2 years also. So the patient will have an arthralgia or arthritis, alopecia, depression, fatigue, and mood disorders also. Factor which predispose the patient to the chronic disease are comorbidities like an osteoarthritis and diabetes. Old age people more than 35, 45 years age, then these people have more problem with chronicity. High viremia and severe disease during acute stage also predispose them. Other autoimmune disease, the patient with like a psoriasis or other kind of autoimmune disease, they are more prone for chronicity of disease. So how you diagnose? Basically, a typical clinical criteria where you have an acute onset of fever with arthritis or arthralgias. In epidemiological criteria means the person is residing in epidemiological area or coming from there in last 15 days. And laboratory criteria where you do viral RNA detection or IgM or IgG detection. So you can see here, if it is less than 6 days, always do an RT-PCR. If it is positive, you're diagnosed. If it is negative, you go for an IgM test. And if the IgM test is positive, then it is positive. If it is negative, then mostly it is not chikungunya, unless you are clinically very suspicious about it. Now coming to some special situation like pregnancy and chikungunya. So in pregnancy, the chikungunya virus can be transmitted through placenta in 50% patients. So in third trimester, if the patient is become pregnant, there is a chances for that neonatal transmission is there. When the neonate get infected, there is a fever, poor feeding, rash, and limb edema which happens. They found that there's a neurodevelopment delay which happens at 2 years in such people, much more common. If the mother develops antibody at the end of fifth or sixth day, the antibody also get transmitted to the baby, and which helps in protection of the baby. So, if what they are trying to do, if there is less than 34 weeks pregnancy, they are trying to prolong the pregnancy for 1 or 2 more weeks, and that how you can have a lesser effect of the virus on the baby. In children, the chikungunya is the asymptomatic infections are much more common. Otherwise, they are very similar to adults, but the severity is much more less, and chronic phase is not very common. So they are blessed in the nature. So what they say is that in children and in neonates, in old population, the interferon response is not that strong, and that's why the viral protection doesn't happen that good in the initial phase, and that's why neonates and elderly people, they have a much more severe disease at the start, and that's why they have more prone for mortality. In comorbidities in chikungunya, the special mention should be diabetes. So in diabetes, what happens is that the glycemic controls deteriorates during the chikungunya. So the many people will have a high sugars, not because of steroid, but otherwise also. So the more severity and duration of disease that happens, and there are more complications, and AKI is much more common in diabetic patients. And mortality is also higher in patients with the uncontrolled diabetes with chikungunya. So now coming to chikungunya and co-infections. So looking at that, so dengue and chikungunya, they can be co-infected in patient in around 12.5% patient in a trial. That's a very huge number, because if the patient is having dengue along with chikungunya, you should be avoiding NSAID for 40 till 48 hours patient until the patient becomes afebrile. If you give that, the chance for dengue hemorrhagic shock syndrome is much more, and that's why you should avoid it. Such patients have more diarrhea, rash, arthritis, and platelets are low. The mortality is also on a higher side. Chikungunya with HIV is a more of lymphopenia, and chikungunya with Zika is more of an arthritis. The only thing that is good is that when chikungunya happens with malaria, the less severe chikungunya arthritis. Now, there's one theory which is going on, and that is the as the Plasmodium falciparum has incidence has gone down in Africa and in tropical countries like India, the chance for chikungunya has gone up. So initially, apparently also we might had some chikungunya, but now the chikungunya which is coming is much more severe because we don't have that good falciparum coverage in our population. So how chikungunya chronic arthritis differs from rheumatoid arthritis? So rheumatoid arthritis, the joint involvement is almost all joints can be involved. Chikungunya mainly peripheral joints are involved. Central joints are much less involved. In spine, the cervical spine is much more common in chikungunya, while cervical spine is common in rheumatoid. In chikungunya is lumbar spine which is involved. Erosions are much common in RA because the neutrophils are there. In chikungunya, generally the monocyte macrophages are there. That's why you see less erosions. Lymphedema is much more common with chikungunya arthritis than rheumatoid arthritis. So if you see a patient with much more lymphedema, think of chikungunya first. So how we treat chikungunya? So it's a very complex question because we don't have any answers yet. Uh, After around 15 years of disease, also we don't know exactly how to treat. So there are various trial which has happened, but in acute phase, in 0 to 3 to 4 weeks, you give paracetamol, NSAIDs, you give pregabalin and duloxetine like drugs, you give morphine and codeine like opioid drugs. You can use low dose steroid at the start. They found the chikungunya virus to be present inside the joint at the start. In initial 4 weeks, they found that, and that's why you avoid giving any drug or large dose steroid at the start so that you can avoid having problems of the more viral replication inside the joint and more viral persistent inside the joint. So to prevent that, you do not give higher dose of steroid, you do not use any DMARS at the start. So they have used etanercept, a TNF blocker at the in acute stage in mice, and they found that the mouse which receive etanercept they have higher mortality because the etanercept will prevent the TNF and that increase the virus replication and causes more systemic symptom and lead to mortality. In subacute phase, NSAID steroid acetaminophen should be used. There was a doubt that we should use hydroxychloroquine or not. So there, among the three trials, one trial was positive, the second trial was negative. The third trial showed there's an increased chance for chronicity or increased chance for viral replication in subacute phase also. So if you feel the patient is having more benefit than risk, then you should use, but otherwise avoid, as HCQ is also in subacute phase. In chronic phase, when it is more than 8 weeks, it behaves like early rheumatoid arthritis. So you should treat like with DMARS. You will be using methotrexate. So there are around 140 case reports of methotrexate use, and among that, six retrospective trial where they use methotrexate in a dose of 15 to 25 milligram. They found the methotrexate is an effective drug in preventing the symptoms of chronic chikungunya arthritis. There was one more trial where they used methotrexate, sulfasalazine, and hydroxychloroquine as a combination. They found it is effective. HCQS as an alone has not been found effective in a patient with a chronic chikungunya arthritis. So there was much deal regarding HCQS also in COVID and also in chikungunya, but at the end they found that it is not very effective in such patient, and we should not be using it alone as far as possible. So there are experimental treatment which are there. So etanercept they have found to be negative trial which was there. Tocilizumab rituximab has not been tested, but tocilizumab will be effective. If you see the recent COVID data also, the tocilizumab they give in a as an IL-6 blocker in COVID also, but in specific situation, especially when there's an immune response is there and they want to prevent that. Similarly, in COVID also, when we are seeing the immune response, we might be thinking of tocilizumab, but there is no trial for that. Abatacept has been found as a CTLA4 blocker. It has been found to preventing the chronicity of chikungunya. There is a one more plasma like neutralizing plasma which was found, but generally by the time patient comes to you around fifth or sixth day, there is IgM production which is already there, so it doesn't help in preventing the disease. There are two more drugs which are found to be useful, but the trial are still remaining, tomatidine and bindidet. So might be the future in such case. Now, when you cannot treat properly, what you can do? You can vaccinate the patient. So the vaccines, uh, The COVID vaccine has come in 1 year, but the chikungunya vaccine has taken around 15 years, and still it is not coming into life, I can say. So the 4 vaccine is in phase 1 trial, two vaccine in phase 2, and one in phase 3 trial. Now, the problem here is slightly different. The chikungunya is an epidemic, so with endemicity. So you cannot predict who will get disease, and the trial for vaccine is not very slightly complicated in that sense. Only one serotype the vaccine provides the protection. So there are 4 serotypes. So at the end, we might have to go for polyvalent vaccine, which might be available in near future. There's one more innovative thing that they have done. There's a bacteria, gram-negative bacteria, Wolbachia, which infects the Aedes aegypti and kills them. So that's how it can prevent the spread of chikungunya. So it's a possible thing that can be done in future. So treatment summary, what I can say is in acute phase, avoid hydroxychloroquine, other DMARDs. Low dose steroid and NSAID paracetamol are safe in early disease. So then 4 weeks you can think of that. If it is more than 6 to 8 weeks, treat like an early rheumatoid arthritis with methotrexate, sulfasalazine, hydroxychloroquine. How long we will give, no one knows. But yes, we should give a time duration of around 6 months to 2 years. Uh, so that is how long you will be using the drug. May consider DMARD in people at risk for chronicity when you know that the person has diabetes, the person has very severe acute disease. Those are the patient you start maybe in subacute, may start in subacute or chronic phase early on, so that they might you might be able to stop them to grow into the chronic phase. Other autoimmune disease like psoriasis or they predispose the patient to have an arthritis. Any questions from my end? Thank you.
Sir, thank you very much for today's sessions are very nice sessions and have got enlightened today's session, sir. There are some few questions, sir. Dr. Kinnar
Sure.
Avasya asking one question, sir. There is
Sure.
any role of curcumin in chikungunya arthritis, sir?
Yes, so there are case reports of use of curcumin in chikungunya arthritis, but they are not very strong. So curcumin basically works as an antioxidant. So there was small trial where they found that curcumin might be effective in preventing the chronicity, but one more trial has failed to show any benefit. So we exactly do not know, but it might be effective, but there are no data to support my claim.
Yes, thank you, sir. Second question, sir. Dr. Piyush asking, what is viral arthritis and how can we diagnose?
So the viral arthritis is very typical when a patient comes to you with maybe fever or feverish feeling and acute onset arthritis. So any patient with rheumatoid arthritis will not have in a day involvement of 10-15 joints. Here the person will come with incapacitating arthritis. In a day, in night person has slept normally, and in morning when he wakes up, he will be like that, I cannot get up. It is so severe and it is so acute and it is so incapacitating. If that happens, then you always start thinking that is it a viral arthritis or not. If it is within 15, it is within 6 days, do an RT-PCR. It is more than 6 days, do an IgM test, and that's how you diagnose a viral arthritis. So many viruses can cause that, but mostly chikungunya is the most prevalent virus. Dengue itself also can cause viral arthritis. Zika can also cause viral arthritis. Almost all alpha viruses can cause viral arthritis, but much more common, the most common culprit is chikungunya.
Okay, sir. Thank you very much, sir. And very
Sure.
nice and wonderful sessions today. And thank you very much, all the doctors for attending and giving us today time and attend a wonderful session today. Thank
Sure.
you.
Okay. Thank you. Thank you very much.
Thank you very much.
Done, sir.
Done from my anything else you want?
No, sir. No, sir. Thank you, sir.
Sure. Thank you. Thank you very much.